Hi, my name is Dr. Amanda Muir, and I am a gastroenterologist at the Children's Hospital of Philadelphia. On behalf of the Consortium of Eosinophilic Gastrointestinal Disease Researchers, I am here to review common definitions for eosinophilic gastrointestinal diseases. In this video, we will be discussing the most common EGID, eosinophilic esophagitis. Eosinophilic gastrointestinal diseases, or EGIDs, are generally categorized as allergic disorders of the gastrointestinal tract. These disorders are named and best known for their association with eosinophils. Eosinophils make up a small fraction of the white blood cells in the peripheral blood, but are also found normally in many tissues throughout the body. Eosinophils function in a variety of ways to protect the host, including having antiparasitic and antibacterial functions. Eosinophils can modify the inflammatory response and are associated with allergic disorders. In EGID, there is abnormal accumulation of eosinophils in the gastrointestinal tract, leading to dysfunction. Eosinophilic esophagitis, or EoE, is the most common of the EGIDs. While it is still considered a rare disease, its incidence and prevalence have both significantly increased over the past decade. While recognition of EoE has also increased during this time period, the changes in incidence and prevalence have increased at a higher rate than would be expected from increased recognition alone. This suggests that EoE is occurring more frequently. Although the etiology of EoE is unknown, evidence suggests that an allergic, environmental, and genetic components drive the development of this disorder. The vast majority of patients with EoE have a history of other atopic disorders, including asthma, food allergies, seasonal allergies, and atopic dermatitis. Research into the mechanisms of EoE demonstrates similar Th2 pathways as seen in these atopic conditions. However, there are distinct differences. For example, although EoE is a food-driven disease in the majority of individuals, it's not dependent on IgE sensitization as is seen in food anaphylaxis. And while atopic dermatitis and EoE are both associated with mutations in genes associated with barrier function, such as desmoglein 1, there are unique gene patterns and mutations in EoE, such as calpain-14. Recent research has identified other risk factors for EoE. Environmental factors such as early life antibiotic use, cesarean birth, formula feeding, and cold, arid climates are all associated with an increased risk of EoE. EoE is more common in males compared to females, and there is a 10 to 64-fold increase in risk in family members of patients with EoE. Further work utilizing advanced methods such as gene expression profiling, epigenomics, and metabolomics should aid in the further understanding of EoE mechanisms. Clinically, EoE can present in a variety of ways. Often the presentation is different based on the age of the affected individual. Infants and young children frequently present with feeding difficulties, recurrent vomiting, or even failure to thrive. Older children can present with abdominal pain, heartburn, reflux, and vomiting. In adolescents and adults, dysphagia is the most common presenting symptom, and many individuals experience impaction of foods while swallowing. None of these symptoms are unique to EoE and can be seen in a variety of other conditions such as gastroesophageal reflux, esophageal spasms, autoimmune disorders, or anatomic defects. This can lead to delays in diagnosis of EoE if a high index of suspicion is not present. The diagnosis of EoE requires two things: symptoms of esophageal dysfunction and finding of increased tissue eosinophils on a biopsy of the esophagus. EoE cannot be diagnosed without endoscopic evaluation of the esophagus, as there are no laboratory tests available. During endoscopy, many affected individuals will have visual changes suggestive of EoE, including loss of normal vascularity, furrowing, even plaques or ulcerations. As mentioned, biopsy of the esophagus reveals increased eosinophil numbers and activity. Eosinophils are not a normal resident of the esophagus, and their presence is often indicative of disease. Low numbers of eosinophils can be found in other disorders such as reflux. A threshold of at least 15 eosinophils per high power field is considered diagnostic for EoE. When combined with other histologic changes, this threshold is even more accurate. Treatment of EoE can generally be broken down into two categories: food elimination diets and medications. Food elimination diets involve the removal of suspected food triggers. Currently, there is no test to accurately identify food triggers. Common foods that are implicated in EoE include cow's milk, wheat, hen's eggs, peanuts, tree nuts, fish, and shellfish. There are likely regional variations in food triggers based on common diets. Removal of food can be done one at a time or in groupings, such as the 6-food elimination diet that requires removal of all the common food triggers mentioned. The most effective diet is the elemental diet that removes all food and utilizes an elemental formula to provide nutrition. There can be significant barriers to food elimination diets, such as increased cost, poor insurance coverage of elemental formulas, and decreased quality of life for individuals and families. There are a variety of medications that have been utilized to treat EoE. Proton pump inhibitors, or PPIs, are common first-line medications and can be effective in many patients. Swallowed, topical corticosteroids such as fluticasone propionate or budesonide are also effective in the treatment of reducing symptoms and tissue eosinophil counts. Unfortunately, neither class of medication is approved by the FDA for use in EoE. There is concern with both classes regarding long-term side effects. Recently, dupilumab, a biologic medication that blocks the IL-4 receptor, was approved for EoE. Approval of this medication signals a new phase for EGIDs that more effective treatments are coming. There are a variety of areas of active research in EoE. Little is known regarding the natural history of EoE or long-term outcomes for many individuals. Determining who is at risk for fibrosis of the esophagus could be important in choosing initial therapies. For those who already have fibrosis, research is needed to determine if this can be reversed in order to prevent complications such as food impaction. As mentioned, there are no biomarkers for disease activity, nor are there tests to accurately identify culprit food triggers. And finally, more therapies are needed to treat EoE and other EGIDs. The Consortium of Eosinophilic Gastrointestinal Disease researchers aim to address these areas of need. This work is accomplished by partnership with patients and patient advocacy groups across the country and partnership with the FDA to focus on how best to meet the needs of affected individuals.